Hello, welcome to your lecture on Introduction to Fetal Monitoring. I want to first begin by letting you know a little bit about the history of fetal monitoring. It was studied in the 1960s comparing it to Doppler. And what they found is that fetal monitoring was shown to decrease the risk of stillbirth in fetuses. By the 1970s, 60s to 70s, fetal monitoring became more widely used. And even though we utilize fetal monitoring on a continuous basis, it did not decrease the risk of cerebral palsy, but it did increase the risk of cesarean births. So it kind of has a good component, but then a not so good component in that it increased the risk of cesareans. And the reason for this is that we tend to intervene too early when we interpret some of these strips. So we are going to go over fetal monitoring. This is a brief overview. This is a very broad topic, so you aren't expected to know the complicated aspects of it, just the basic information, and you need to know the terminology. So this is typically what we see when a patient comes in for evaluation. They may come in to be triaged, or they may come in to be induced, or they may come in labor. And so in any case, we're going to put the fetal monitor on. Typically, if they're over 25 weeks, we might put the fetal monitor on, but just be aware that we're not really able to interpret with accuracy some of the information unless they're at least 28 weeks gestation. Then we start to be able to interpret, okay, this is what's going on with the baby. Because the fetus doesn't have the neurological maturity to produce certain components, that's why we don't really interpret what we're seeing until they reach that 28 weeks. So you can see there on the left, you have a lady there. She's got two straps on her belly. The top strap is called the toco, and what that is it measures the contractions. You can see where it's placed. It's kind of higher up on her belly. This is the fundus. This is the top part of the uterus. Now contractions originate from the fundus and move down. So that's why we place that monitor up high. Underneath that circle is a little button. And when that button gets compressed, when her uterus firms up, that's what creates the bell-shaped curve of the contraction. Now the bottom monitor there is a fetal heart rate monitor. So we will go over in a few minutes how we kind of determine where to place it, but generally it's going to be kind of on the lower part of the mom's abdomen because the head is typically down there, and that's where the fetal back is. Now you find the heart rate best where the fetal back is located. And we put transducer jelly on the underside of that monitor and place it on her belly so that it can transmit the fetal heart rate signal. That signal and the uterine contractions, they plug into the monitor on the right. Now this gives us a lot of information. So the number on the left there in orange is the fetal heart rate, okay, 148. The green number, the 25, is the contraction monitor. So that number will tend to rise as her belly gets firm, and you'll see that. To the far right, you can see two numbers there. These monitors have the capability of monitoring twins. Below the fetal heart rate on the left is the blood pressure. It also detects the pulse, and you can get the mom's pulse ox. So as you can see, these monitors do a lot. To the very far right, you can see some paper coming out. Now this paper is part of the medical record. We used to just have that to keep as part of the proof of the baby's heart rate, but now a lot of the information is archived in the computer. But these still can print out the strip. Okay, so what are our goals? Okay, we talked about on the left all that information there regarding what the monitor does. Now, the primary objectives. So this is really important to remember, these three things. Okay, so provide information about fetal oxygenation. As you can see there, I have oxygenation underlined. I'm going to talk about oxygenation a lot because that's what we're concerned with. This is how we tell if there's fetal well-being. Do we need to deliver this patient right away, or can we allow her to continue to labor? And we want to prevent fetal injury from impaired oxygenation. We want to detect fetal heart rate change before they can become prolonged and profound. So when we're looking at these fetal monitor tracings, we're looking over a period of time. We can tell very little by looking at a small piece of it. You have to go back, what was going on before, and then we have to continue to monitor. How are things evolving with this patient? Intervene through prompt delivery prior to significant fetal injury. So we have to determine, based on looking at the tracing, how do we know that that is fetal injury, or we're heading in that direction? Okay, keep in mind you have two patients. Okay, you have the mom and the fetus. Okay, so you have to monitor the conditions of both patients. So in terms of fetal oxygenation, it's a transfer of oxygen from the environment to the fetus. Now the environment for that fetus is the uterus. It's the maternal oxygen ability to oxygenate that fetus. Fetal response to normal oxygenation. And this is what we see via the fetal monitor. The fetal heart rate pattern gives us information about oxygenation. And we discuss oxygen pathways. This is a great slide because it's showing you here the oxygen pathway. You have the environment. So you have the maternal lungs, heart, vasculature, the uterus, placenta, and cord. These all have to be working well in order for the fetus to be well oxygenated. And I want you to think about maternal conditions. If you have a patient with heart disease, you have a patient with asthma, severe asthma mostly, there's a problem with her blood pressure. She has peripheral vascular resistance. What about the uterine environment? What about the placenta? Do you have a functioning placenta? Is there narrowing in the cord? Is there a cord around the neck or a true knot in the cord? All of these things are going to affect the oxygen pathway. So you need to think about that. Then you're getting to the fetus and the fetal response. Okay? Is the baby experiencing hypoxemia? Is it leading to hypoxia? Is it leading to metabolic acidosis, metabolic acidemia, and then potential injury? Because once you get to the level of metabolic acidemia, that is really the end point. And our fetal monitor is going to give us that information. We just have to be able to interpret it correctly. Now, I want you to think about hypoxemia and hypoxia for a minute. It is normal for the baby to have a temporary disruption in oxygenation during labor, and this occurs through uterine contractions, because when the uterus is contracting, oxygen supply is cut off. In a normal, healthy fetus, they can overcome this. They're very resilient. They can handle the stresses of labor. But if you have a baby that's sick in there, or they have intrauterine growth restriction, or they have something going on, they're not going to respond as well. So you can predict that these babies may not labor. They may not tolerate it. So if you're thinking in terms of these things, you can kind of predict, okay, what's going to happen here? All right, we talked about fetal back and finding the fetal heart rate. So you're going to use Leopold's maneuver. And I tell students, put your hands on the patient's belly. Don't be afraid to touch the patient, okay? Not only that, you're also going to be feeling for contractions. So you want to be able to get familiar with the patient's pregnant belly. You're going to feel, like you can see in photograph A, you want to feel in the fundus. Again, this is the top part of the uterus. What are you feeling? Does it feel round and curvy and kind of soft? You probably have a buttocks. And that's really what we want there, because we want the baby to be head down. Now, if you're feeling something really hard and bouncy and it's moving around a lot, you probably have a head, so you have a breech presentation. Okay, if you're going to be, you want to move down her belly to the sides. What are you feeling on each side? If you feel something firm and hard, that's probably the baby's back, okay? And that's where you want to place that fetal monitor, because that's where it's best heard. All right? C, you want to feel in the pelvis. What are you feeling down there? And you want to push your fingers in a little bit. And you want to kind of trap that head with your fingers, move it back and forth. If it's round and mobile and hard, you probably have a head. If it's just kind of stuck in there and you can't really move it, you might have a buttocks, okay? Which you have a breech presentation. If the buttocks is presenting, it's a breech, a frank breech presentation. Now D on the far right, that's going to be a little bit more difficult for you to assess, especially if the head is really, really low in the pelvis. And that's just really telling us position. The main things you really want to be concerned with on Leopold's is A, B, and C. Now, if you are unsure, this is not 100%, okay? If you're not really sure that what you're feeling is a head, especially down in the pelvis, you always want to grab an ultrasound and confirm presentation, because you never want to labor a patient or start an induction on a patient where you're not sure of presentation. Now, when we do a vaginal exam, a lot of times we can feel a presenting part. If the patient's a little bit dilated, we might be able to tell, but if they're not, it's kind of difficult. So you want to get an ultrasound. And again, this one is just showing you placement of the monitors. Okay, so up top there you have your TOCO, measures contractions. Below you have your fetal heart rate monitor, which is measuring the fetal heart rate. Okay, so now going to this display, the paper. And this is what you're going to see. Okay, so the top graph there is the fetal heart rate. And you want to keep these two graphs separate. Okay, and you want to keep each set of terminology separate. Okay, so you've got the numbers there on the side, and that's going to show you the fetal heart rate. Now, if you're looking at the blue area up top, that's your normal fetal heart rate baseline range. Okay, and we're going to talk about that in a minute. Okay, if you're looking at terms of the graph, each large box with the solid red lines is 1 minute. Each of the small little boxes is going to be 10 seconds. Okay, same thing going up, they're increments of 10. Okay, so keep that kind of straight. Now, below you have your contractions. Okay, so each red solid line is a minute. Each each little line box there is 10 seconds across. Okay, going up it's smaller. They go up in increments of 5. Okay, that scale on the left is only used when we're doing internal monitoring, and that's where we're measuring intensity of the contractions by a number. We do this via a monitor called an intrauterine pressure catheter, or IUPC. Now, if you're measuring from an external monitor, you're going to be feeling the patient's belly. You're going to be palpating contractions. Now, when you do this, the way we document it is you want to make sure that you're in there so when she starts a contraction, you can measure. Okay, if you feel like the tip of your nose, that's a mild contraction. If you feel your chin, that's a moderate, and your forehead is firm. And that's exactly how you're going to document in the medical record when you have an external. And you want to be making sure that you're palpating her contractions. Now, you're also going to measure the resting tone. Okay, so with an external monitor, you want to make sure that after the contraction ends that she has a soft uterus. She shouldn't be really tight. Okay, so you're going to document it as soft. IUPC, if you take this monitor, you look at the peak of each contraction, you're measuring directly on that scale. Where is it? Don't use the one on the right, use the one on the left. So if you're looking there, it's a little bit difficult to see, but it looks like it's going up to about 35 to 40. And we're going to practice with some of these strips so you'll be able to see. But you're actually documenting a number when you're using the IUPC. This is just showing you again what all the boxes represent. The large solid boxes are 60 seconds or a minute long. Small ones are 10 seconds. You have increments going up and down on the fetal heart rate of 10, and then up and down on the contractions of 5. Very important you know how to read these. Okay, So let's talk about contractions. Contractions are measured in terms of frequency, duration, intensity, and resting tone. Okay? Okay, so let's talk about frequency. This is how often the contraction occurs. Now you're measuring from the beginning of one contraction until the beginning of the next contraction. So when we're educating patients about this, this is what we're telling them. And if you look here at this example, you measure here from the beginning, 1, 2, 1, 2. Those are about 1 to 2 minutes apart. Now you can document a range. And you're looking at about a 10-minute increment of time. Okay, so this is kind of short. This is like 6 minutes. But you're going to really look at a 10-minute strip and then you're going to measure them. So those would be documented as 1 to 2 minutes apart. Okay? Next, you're going to determine duration. Duration is how long the contraction lasts. Okay? So you're looking underneath here and you're counting in seconds. We always document duration in seconds. Okay? So here in this example, you have one that's 80 seconds, maybe 70, 60, and again, you can put a range, 60 to 80 seconds. Okay, that's how you're documenting. Intensity, again, you're documenting where it peaks. Okay, right here, the top of the contraction. If it's an IUPC, that's going to be 50. If you're measuring with an external, you're going to measure, is that mild, moderate, or firm? And then lastly, you're documenting resting tone. Now on here with an IUPC, technically you put 0. It should really never be 0. It should be at least 10 to 20 for the resting tone on an IUPC. Okay, if you're measuring with an external, it's going to be soft. Okay, or if it's not soft, if she's not resting, you want to note that. Okay, so let's talk about a term. If you have 5 or more uterine contractions in a 10-minute window, okay, or actually, sorry, more than 5 in a 10-minute window, average over 30 minutes, or 2 uterine contractions lasting more than 120 seconds in duration, this is known as tachysystole and requires nurse intervention. So this essentially just means her contractions are either too long or she's having too many, okay? So tachysystole, the number one cause, and you want to make sure you know this, you could be asked on an exam, is the use of Pitocin, okay? We use Pitocin to induce or augment labor, and when we have too much of it going, we can cause this condition, okay? A lot of what you do with this is going to be dependent on how the baby's heart rate looks, and we're going to talk about that interpretation in a minute. But if you have an oxygenated fetus, you determine that, and you have tachysystole, okay, you probably want to turn it down. If it's going on longer than 10 minutes, you have that 30-minute window. But what's going to happen is you're going to lose oxygenation. When the patient has tachysystole, the uterus is not relaxing. I want you to think about it as the baby is holding its breath every time mom has a contraction. And if she's contracting every minute and she has tachysystole, the baby's not getting very much oxygen during that time. You want those contractions spaced out, okay? Not too far spaced out, but you want them spaced out enough that they have a good labor pattern, but they're not contracting too frequently. And if they are, you need to back off on the Pitocin. You either need to turn it off or you need to turn it down, okay? Nurses have the liberty to do this on labor and delivery. You run the Pitocin. The provider writes the order, you control it. So based on what you're interpreting. Okay, so I just wanted to make that note. Now, this is showing you tachysystole, okay? We talked about the potential causes. Okay, what if a patient comes into the unit and she's just doing this on her own, okay? She is having a lot of contractions and it looks like she's on Pitocin, but she's not, okay? I can tell you this baby, without us going over interpretation yet, doesn't look terrible. It's got oxygenation. However, after some time goes by of this contraction pattern, it's not going to continue, Okay, I can tell you that. That's why you want to intervene. You don't want to just let this go on. Okay, and you'll have providers try to bully you into keeping the Pitocin on. Don't do that. You got to be the advocate as a nurse. So if a patient walks in and they have this kind of pattern, you got to suspect placental abruption, especially if the patient is having a lot of pain. Okay, so this isn't a normal looking pattern. One of the things you can do is give the patient an IV fluid bolus to space these out. Okay, she might be a little dehydrated. You can space out the contractions, okay, a little bit. But if she's truly having an abruption, yeah, you're going to see this kind of pattern. Okay, let's talk about fetal monitoring interpretation. The NICHD, or the National Institute of Child Health and Human Development, developed this nomenclature. And I can tell you, if you plan to go into labor and delivery when you graduate, or that's where you want to work, you 100% must know this terminology. Okay, labor and delivery is one of the most highly litigious, sued areas of medicine. And nurses get implicated a lot because there's a lot of leeway. We have a lot of independence. So you need to know your strips and you need to know your terminology. Okay, and I'll just say that much. Okay, so you want to determine the following when you're looking at the fetal heart rate. Baseline. We talked about that blue shaded area a little earlier, okay? And we're going to go over that. What's the baseline? That's the first thing you want to look at. Fetal heart rate variability, okay? We're going to talk a lot about that. Are heart rate accelerations present? You're going to note yes or no. Are decelerations present, and if yes, which variety? Determine the fetal heart rate category. We only determine categories in labor. If we're doing antepartum surveillance with a fetal monitor, that's a different thing. That's a non-stress test, which is something different. Is intervention necessary? And we're going to go through each of those interventions because there are things we can do to try to improve how the strip looks. Okay, so looking at the baseline. You need to know the normal fetal heart rate baseline. You will be asked on an exam, so I'm telling you, make sure you know. It's 110 to 160. Now, what you want to do is you want to look at the heart rate. Sometimes the baby's really active, okay? When the baby's active, it's kind of hard to tell a baseline. When it's kind of settled down and more quiet or it's sleeping, it's a lot easier to tell, okay? But you can look at pieces of 2 minutes on the strip to determine that. But really, 10 minutes is a good period of time to determine what is the baseline, okay? And sometimes if you draw an imaginary straight line through the place where the heart rate falls more often, it's easier to tell. Because one part of it may be 130, you may get to the end, it may be more like 140, okay? But see where it falls most often. And you're not wrong, but just kind of be as accurate as you can with it. You don't want to include any decelerations where it falls below or accelerations where it rises above to determine the baseline. So you want to look in between that. You do need at least 20 minutes to determine a baseline, like for sure. I mean, 10 minutes, if you just have a little finite period of time where you're concerned, you might look at least 10 minutes and go by that. But if say you have a patient coming in for an induction, you really want a good full 20 minutes to determine what's going on before you start anything. All right, let's talk about variability. Okay, there's 4 types that you need to know. Absent. There's really no change in the baseline. They can have a normal baseline with absent variability, but this is a very ominous sign. It's not good. It essentially means that you have a dying fetus, okay, if you detect absent variability. And I can tell you that absent variability very rarely evolves to minimal or moderate, okay? And patients often walk in the door with absent variability. It's not something that we see over time because hopefully we're recognizing the strip is deteriorating before it reaches that point. So just be aware of that. Minimal variability if you're looking at the little box, it's 10 seconds, it's 0 to 5 beats of change. It's going to be half of that box, less or half. It's never going to go the full 10 beats, okay, in that box, okay. Moderate variability is 6 to 25 beats of change. It's more than a half a box or 2.5 boxes. The good news about moderate variability is it's very easy to detect. If you see it, you know you have it, no shadow of a doubt. The other thing that you need to know, I want you to remember this. If you have moderate variability, you have an oxygenated fetus, period. It doesn't matter if that fetus is having decelerations. It doesn't matter. If you have moderate variability, you have oxygenation, and your baby or your fetus has oxygen reserve. And that's really important because oftentimes providers will just look at the decels and they're like, oh my gosh, I need to crash section this patient. No, don't do that. We're going to do interventions, we're going to try to correct it, and then see where we are. But you know that it's not a crash situation, okay? So that's an important thing to remember. Now, you have marked variability, which is greater than 25 beats, more than 2.5 boxes. We don't really know what causes marked variability. We think it may be related to development of hypoxia or hypoxemia, but there's really no studies that clearly identify what causes marked variability. Now, a couple of things that you might see with that is if they have an internal monitor, a fetal scalp electrode, which is an internal fetal heart rate that we put on the baby's head, with a little corkscrew metal device, and I'm going to show you a picture coming up soon about that. There's a lot of artifact because it's a wire and it kind of rubs against things. And so you might get some artifact. Another theory is that the baby has arrhythmia. Sometimes we might see that. And usually we can hear it with our ears if the baby has a skipped heartbeat or an arrhythmia. So that's kind of what we think about with marked variability. Okay, we talked about internal monitors, so I wanted to show you what these look like. This is your IUPC, intrauterine pressure catheter, and this is the one that measures the contractions from the inside. So this is where you're measuring with that scale the intensity, okay? Fetal scalp electrode is there on the right-hand side, and again, it's like a little corkscrew that goes just under the scalp on the baby's head, and it picks up the fetal heart rate. You have to be a labor and delivery nurse for a year and have advanced fetal monitoring before you can place an IUPC. When you are a new nurse on labor and delivery, you will be taught how to place a fetal scalp electrode. They both require ruptured membranes. Okay, so if the patient has an intact bag of water, we can't use these. But sometimes we will rupture them to get these monitors in because sometimes we need to see what's going on. Okay, we can't pick it up with the external for whatever reason, and then we need to see what's going on. Okay, so here's some indications. Okay, for the fetal scalp electrode, we're unable to accurately trace the fetal heart rate. And a lot of times if the mom's in a lot of pain, discomfort, she's a little heavier set, it can be difficult to monitor the baby. And so we'll get like this broken tracing where we can't really see what's going on. Okay, and sometimes we may hear decelerations. And so these are cases where we really need to get that monitor on. We need to see what's going on. Contraindications, of course, maternal HIV and herpes. And we're not going to be laboring a patient that has active herpes, okay? We're going to hopefully detect that before, okay? But we do labor women with HIV, and we don't want to introduce any blood or secretions to the baby if possible. Now, for the IUPC, unable to trace contractions accurately in labor. And this is mostly the case when the patient's not changing their cervix. It's been hours and hours, and now we're putting an IUPC in to see if, she needs stronger contractions, to see if her contractions are adequate. And also if she's on a high dose of Pitocin. Usually if they're getting close to 20 milliunits of Pitocin, we tend to put that IUPC in so we can really see what's going on because that helps guide us to adjusting her Pitocin drip, okay? Need for amnioinfusion for variable deceleration. So again, the IUPC will do this. I'm going to go back a little bit here. Oh, I can't go back. Okay, but anyway, the IUPC does have a port. You can hook up an IV line, so you prime an IV tubing just like you would to start an IV. You're usually using normal saline or lactated ringers, and you want to make sure you always use room temperature fluid. You never want to use warmed fluid. Use room temperature, you're hooking it up into that port, and you're giving the patient about a 500 ml bolus. The provider does have to order that. You can't just hang it, so they have to order it. And then you run it in, and then usually you have to check under the patient, change their pad. Their pad should be soaked. The fluid should be coming out. What this does is when the patient's ruptured, oftentimes they'll get cord compression due to the lack of fluid. And we'll talk about variable decelerations in just a minute. But that helps float the cord to prevent it from getting compressed. Okay, it only is indicated for variable decelerations, nothing else. Okay, that's the only indication. Your textbook talks about using it to wash out meconium that's in the fluid. Its studies have shown that it does not prevent meconium aspiration. So your book is outdated, so don't go by that information. It's only variable decelerations. Okay, so again, here's showing you the variability. Minimal variability. Okay, let's talk about that. We didn't really discuss what this means. Okay, we talked about moderate and oxygenation. Okay, minimal variability can be concerning or it can be completely normal. Okay, so you have to think about what's going on with the baby, the patient. Okay, because these are factors that can affect the variability. Okay, let me give you some examples. If you have a patient come in and they have moderate variability, and then all of a sudden the strip goes to minimal variability and is staying that way, like 20 minutes or so. I'm not that worried because I know the baby is probably in a sleep cycle. Okay, babies asleep have minimal variability. They're not moving very much. Okay, so if I know that I've seen moderate variability before this, I'm less concerned about the baby. I know it's a sleep cycle. Okay, same thing if I give my patient fentanyl for pain in labor. If I have moderate variability and then, I'm starting to see minimal after I give her the fentanyl, I know that's why, okay? If we have a rationale for it, we're not concerned. Now, if a patient comes in and they're being evaluated and you put them on the monitor and they have minimal variability and this is going on like 20, 30 minutes and you're not seeing any moderate variability or accelerations, which we'll talk about in a minute, I'm a little bit more concerned. Did the patient have a cigarette before she came in? What do cigarettes do? They impede oxygenation through the placenta. Okay, so you're going to see a flatter baby. You're going to see more minimal variability if they just smoked. Okay, is the baby post-dates? Okay, do we have an aging placenta? Something's going on. Okay, and we'll talk about ways to make it look better, but that's a couple examples where you might be worried about it or you might not. Okay, so you have to know what's going on. And that's why it's important to ask the patient, what did you feel the baby move today? Did you just smoke a cigarette? You're trying to figure out why it might look like this. Okay, what's her due date? Is she like a week over her due date? What's going on? Okay, absent, as I said before, this is a dying baby. This is a tracing. The patient walks in the door, probably complaining of no fetal movement or decreased. Okay, this patient will get delivered ASAP. Okay. Mark variability we kind of discussed already, and you can see this is an internal monitor and it is artifact, a lot of that. This is truly marked variability, and so if it's sustained very long, sometimes what I would do is take the external and put it where the baby's back is to see what I can hear. Okay, and if you can hear skipped beats, it's probably an arrhythmia. And most of those do resolve once the baby's born. Okay, so let's talk about accelerations. These are 15 beats above the baseline for at least 15 seconds. You're counting in the boxes here. You can see that. You got 3 nice accelerations right here. Now, we talked about non-stress tests. These are indicated for patients that have hypertension, some other kind of condition in the pregnancy where we're doing fetal surveillance. Diabetes is another one. So if they have at least 2 accelerations in a 20 to 40 minute window of time, that's considered a reactive NST. And we know that with a reactive NST, which is good for about 3 days, we have a very, very low likelihood of stillbirth. Okay, so that's why we do these. And we usually do them twice a week because they're good for about 3 days. So this is just part of antepartum surveillance. Now, if we cannot get a reactive NST, we might do a vibroacoustic stim, and I'll show you what that is in a little bit. But a lot of times it's a buzzer that makes a buzzing sound and it vibrates, and it usually will wake up the baby, and the baby will kind of jump in there, and then you'll have a nice acceleration, and now that the baby is awake, you'll see more moderate variability. Now, if the patient is under 32 weeks, if they have 10 by 10s, those are acceptable, okay? Just because of neurologic maturity of the fetus. So once they're over 28 weeks, though, you should expect to see, over 32 weeks, you should expect to see 15 by 15s. Okay, so I already talked about the non-stress test, but this is the vibroacoustic stimulator. That's what it looks like, okay? If we don't get what we expect to see, we don't get the accelerations, then we'll move on and do what's called a biophysical profile or a BPP. Okay, this is an ultrasound test done that measures amniotic fluid index, heart rate, breathing, gross body movement, fine body movement. So there's 5 criteria. They either get a 2 or a 0. Usually if they're over a 6, that's a good biophysical. If they're under 6, then they may consider delivering the baby depending on gestational age. Okay, so, also, sorry, the NST is part of that. So NST, body movement, breathing, heart rate, and fluid. Okay, so those 5 things. If they get an 8 out of an 8, though, excluding the NST, that's a good biophysical, or at least a 6 out of 8. Okay, this is just showing you a picture of a nice, well-oxygenated fetus. Okay, not very much contraction activity going on. It's kind of hard to see, but you can tell this is an external. Okay, and then you have no doubt, you have accelerations, you have moderate variability. I look at this strip and I can tell you I'm happy with this fetus. It's well oxygenated. I'm not concerned. Okay, here's just showing you pictures of accelerations. Now, a point to make. Accelerations can go over 160, okay? Remember we talked a few minutes ago about normal baseline, 110 to 160. Well, what if it goes up to 180, okay? And you have it, how do you know it's acceleration? Or is it fetal tachycardia, okay? Well, as long as it's not sustained for more than 10 minutes, okay? If that baseline stays up there, that heart rate stays up there for 10 minutes or longer, it's considered a baseline change, and now you have fetal tachycardia. Okay, really different story than acceleration, okay? Because we are concerned about fetal tachycardia. Okay, so let's move on to decelerations now. So there's several types, and we're going to go through each one. It does indicate a disruption in the oxygen pathway. We talked about that a little earlier. Okay, so it can be a maternal physiologic cause, umbilical cord compression, or at the level of the placenta. So early decelerations are a benign and expected part of labor progress. Okay, we're actually really happy when we see early decelerations because what do they mean? We're getting close to having a baby. Okay, so what's happening is the fetal head is getting compressed as it descends down into the pelvis. So the pressure of the descent is causing the deceleration, okay? It's a vasovagal reaction. So it's expected, and we don't get concerned about it. We don't even document early decelerations. Other types of decelerations are treated based on the cause. We need to determine the need for immediate delivery based on the cause and response to the interventions. Okay, so let's go through this. Okay, so we're going to ask ourselves, are decelerations present and which type? Okay, let's start with variables. Okay, variable decelerations are abrupt in nature. Okay, they go at least 15 beats below the baseline. Okay, I want you to think about you're standing on the edge of a cliff and the cliff drops off suddenly. That's what variable decelerations do. I want you to think about variables as being different from the other types of decelerations in the fact that they're based on characteristic, not timing. Okay? The other types, we're going to talk about timing. This one, it's kind of an isolated thing. It drops off, it comes back up. It may happen with a contraction, it may happen independently of a contraction, but they're based on characteristic. Okay? So separate that. We talked about earlies. They usually will mirror the contraction. It starts at the same time and it ends at the same time. Now the key with early decelerations, because if you look here, here's the early, here's the late. They look very similar, don't they? Very similar. If you're just looking at characteristic, which we're not measuring these based on that, I want you to look and see where the heart rate goes back up. Okay, right here in that early, it goes right back up to baseline once the contraction ends. That's your key to knowing this is an early. Okay, it should resolve once the contraction's over. Okay, whereas if you look at the late, it has a late onset. This one has a late onset. It's pretty clear. Not all of them look like this. Okay, so late onset, late recovery. But your late might start back here where the contraction peaks out and then it starts to go down. You have to look at when it recovers. Okay, if it doesn't recover by the time the contraction's over, it's a late deceleration. These are two very different etiologies. Okay, we talked about the early being head compression. Now your variable is cord compression. So remember we talked about that with the amnio infusion. And usually this is due to the cord being compressed due to low fluid. Okay, so that's what's causing that. Now with the late deceleration, you have uteroplacental insufficiency. Something at the level of the placenta is not working. Okay, so oxygen there's a lag time in recovery due to lack of oxygenation to the baby or fetus through the placenta. Then here you have a prolonged deceleration. Okay, this is just usually an acute event, sorry about that, where it stays down. And usually it's caused by like a seizure or it could be like a prolapse cord. But usually you have a prolong, if it's going on longer than 2 minutes, that's going to be a cesarean delivery. We're crashing the patient. Okay, now variable deceleration. Again, this is showing you these look a little bit different. They can be like a V shape. They can be a U shape. You have to look at this abrupt drop, okay? And you have to look at the characteristic. Abrupt drop there, okay? Okay, early deceleration again. It's a very subtle drop. But if you look here when the contraction ends, you take your little line and you're back up to baseline. Okay, that's your early. Someone might argue with you and say, no, that's a late. No, you have to look and see when it recovers to argue your case. Again, your late deceleration. And this one's really obvious. I mean, it's starting on the downslope of that contraction and it doesn't recover until it's well over. And here's a prolonged, okay? And you can see it gradually goes back up. Okay, usually this is what it does. If we're not seeing this recovery going on, we need to take that patient back and get her delivered because the baby's not going to tolerate a low heart rate like that very long. it's going to code is what it's going to do. When it's in the 50s and 60s, it's not going to, yeah, it's not going to tolerate that. And this is probably a patient having a seizure. Okay, we can expect that with a seizure. Okay, this is a sinusoidal fetal heart rate pattern. This is a bad thing. Okay, don't mistake this for variability. If you can see the smooth wave-like sinusoidal pattern here, um, it's very smooth. There's no variability. You're looking at variability within the line. Okay, this is a very smooth wave-like line. This is fetal anemia, usually indication, and this patient will get delivered. This baby, again, is dying. Okay, we need to crash deliver this patient. Okay, this is a great slide to remember, okay? Your deceleration and the cause. Okay, you need to know this. You will be asked on an exam, no shadow of a doubt, about these. You may see this on the NCLEX. So variable, cord compression. Early is head compression. Again, benign. We don't document head compression or earlies. Acceleration, okay. You got oxygenation. And late, placental insufficiency. Okay, so let's talk about categories. Category 1 is good. Okay, again, you can probably detect a category 1 and say, okay, I know my patient is doing fine. My baby looks good. Okay. We know this because they have a normal baseline range, they have moderate variability, they have late or variable decelerations that are absent, they can have early decelerations, and they may or may not have accelerations. And a lot of babies don't have accelerations in labor because remember, again, they're under stress, but it's a stress that they can tolerate. And then your category 3, intervention needed. These patients are going to be delivered, okay? That's going to be your sinusoidal pattern. These are going to be your strips with late decelerations that are recurrent, which I'll explain that in a minute, and absent variability, okay? So they may or may have bradycardia or tachycardia, or they may have a normal baseline. And then variability is absent, late or variable decelerations, recurrent variable or recurrent late. Now, if you're looking at a 10-minute strip, okay, and you've got, let's say, 5 contractions, and you have 3 variables, okay, so you have recurrent variables, and you have that because when they occur 50% of what you're looking at, that's considered recurrent, okay? So 3 out of 5 contractions, you're having variable that's greater than 50%. Category 2 is all the kind of messy stuff in the middle, okay? So category 2s require increased surveillance. Okay, so what that means is you're implementing interventions, which we're going to go over in a minute, but you may have a category 2 that, you know, this patient's probably not going to have a vaginal birth. And I'll give you an example. If you have somebody that came in and you're laboring them and you're having to augment them with Pitocin because they're not changing, okay, their cervix. But every time you try to start the Pitocin, they have a decel, okay, a big decel. Let's just say start having lates. Well, we're not going to really be able to get that patient very far, okay? And if they're having decelerations, that's giving me a clue the baby's not tolerating something in there, okay? So that patient is more than likely going to get a cesarean delivery because we don't want to push the envelope. We don't want to push them into metabolic acidemia, and then we're really in trouble, and then this baby has a poor outcome, okay? So that's an example. Some category 2s will fluctuate back into category 1 once you do your interventions, okay? So it's a variety of things. And you can see there, I'm not going to ask you like, okay, what constitutes a category 2? I'm not going to make you memorize that, but just know that an idea that category 1s are reassuring, category 3s need intervention and delivery most likely, and then category 2s require increased surveillance. Okay, this is just showing you got your category 1 with your moderate variability. Category 2, you're watching. It's not terrible, but you're watching it. Category 3 is warrant delivery. And this is another slide just showing you the NACHD terminology for the categories. Okay, so what do we do? Okay, we have patients that are having variables or having late decelerations. Okay, I want you to first think about etiology. Okay, a lot of times with variables, we just broke the patient's water. Okay, it looked fine before, and now they're ruptured and they lost all this fluid, and now they're having variables. Okay, let's start an amnio infusion. Let's see if they respond to that. Okay, in addition to that, you're going to change positions. Sometimes position change alone will resolve it. Okay, so you'll turn her to her left lateral side. Usually they're going to get the maximum oxygenation to the fetus in that position. If the left doesn't work, move her to the right. You can try hands and knees, hips open with the use of a peanut ball. The peanut ball is really cool. It's like a yoga ball, but it's like a peanut shaped and it helps open the hips and allows for descent of the fetus. You can try a high Fowler's position. Whatever works to improve that strip, okay? If it gets rid of the deceleration, it's working, go with that. Because really what we're doing with uterine resuscitation is we're trying to allow her to labor to get to complete to have a vaginal birth, okay? So we're trying to improve how the strip looks to get her there, okay? To avoid cesarean. But we may not be able to do that in every case. We have to really ultimately end up doing what's safest for the baby. So that's kind of what we're doing. IV fluid bolus, because you want to increase perfusion through the placenta. Apply O2, 10 liters via non-rebreather face mask, because again, you want to maximize oxygenation to the fetus. Turn off the Pitocin. A lot of nurses forget this, okay? Contractions are just going to create more insult to injury. So if you can turn it off, let the baby recover. Sometimes that's what we do, is we turn it off, let baby recover, and then we may try to restart it, okay? And start over again. Administer terbutaline. Terbutaline is used off-label in OB. It's a medication for asthma, but we use it in OB because it stops contractions. So if we have an emergent situation where we have a prolonged deceleration, we're going to give that patient terbutaline because we don't want the contractions to continue. Terbutaline does carry a lot of unpleasant side effects, and it does have a black box warning on it because it does cause tachycardia in the patient, and also causes them to feel very jittery and not feel good. So you kind of have to warn them. But if you're in an emergency, you're having a decel, you want to give it IV push, 0.25 milligrams. It's always going to be the same dose. This is what an amnio infusion looks like. It's just you got your normal saline, you got your pump, it's going into the uterine IUPC, and it's running fluid. Now, you want to make sure with an amnio infusion that you're getting fluid return. You don't want to fill her uterus up full of fluid and rupture her uterus. You have to make sure you have fluid return. And you're going to be documenting that. Patient has good fluid return, pad saturated with fluid. You got to make sure it's coming out. After you give that bolus, sometimes we can run it in at 100 an hour just to keep the fluid continuously running through. But again, you want to make sure whatever you're putting in there is coming out. And that's it. Let's look at a couple strips here. So here, you've got a nice category 1. You got a normal baseline. You got moderate variability. You have accelerations, no decelerations. This is a really good contraction pattern. That's exactly how they should look. They're not too close together. They're not too spaced out. And these are about 1, 2, 1, 2, 3, 1, 2, 3, 1, 2, 2.5 to 3 minutes apart. Perfect. Okay. And usually this is going to be a pattern that they're going to change their cervix. Okay. Again, this is an external, so we can't really measure intensity. We're going again by palpation. All right, this is a great example because this strip is showing you've got moderate variability. Now, if you're looking between here, between these D cells, it's kind of hard to see. you've got moderate variability and you have accelerations, okay? This is a category 2 because you have variables, okay? Look how abruptly these drop. They're very wide, okay? But they are variables, okay? Because of the characteristic. They drop at least 15 beats or abrupt. There are cases where you might have a combination of these, okay? But someone might come and say this is a late because of that. No, you're going by characteristic. Am I concerned about this patient? Well, I know she has moderate variability in accelerations, therefore I know the baby's oxygenated. So I'm not worried in that sense. However, I do want to treat those decelerations because you're going to lose variability over time. If you don't do your interventions, it's not going to continue to be oxygenated. So that's why you want to intervene. And then this patient, I'd give her an amnio infusion, you know, turn her on her side, give her an IV fluid bolus, probably stop Pitocin. But another important factor here is check her cervix. What's going on? Is she close to delivering? I mean, if this patient's like a multiparous patient, we know they're going to go a little faster than a primep, okay? If she's 8 centimeters and she's a multip, I know she's going to deliver soon, okay? But if she's only a prima gravida, her first baby, and she's 4 centimeters and she's doing this, she's probably less likely to make it. And if we can't correct these decelerations, she's probably going to get a cesarean. Okay, so see the difference? Okay, this one here, you've got absent variability. It's like a straight line, right? And look at these decelerations. You've got recurrent lates. Look at when they recover, all the way back here. Okay, you know your contraction's well over, but look at where it recovers. Okay, very, very good picture of late decelerations. So again, this patient's going to probably get a cesarean. We can try to do interventions to see. One case that I will point out, you may have a patient that has a nice strip. Again, this is why you want to look and see what's going on before, okay? You may have a patient that's been laboring. They have, normal baseline. They have a category 1, moderate variability, accelerations, no decels. And then the anesthesiologist comes in and gives that patient an epidural, okay? What happened? And you see this. You probably won't see absent variability though. But you might see minimal and you might see some lates, okay? What's the number one side effect of an epidural? Okay, it's going to be hypotension, okay? These patients often get hypotensive. What happens to perfusion when someone's hypotensive? Decreased, right? If you have decreased perfusion through the placenta, you're going to produce late decelerations, okay? We correct it by giving them fluid. If the blood pressure is low, a lot of times anesthesia will come in and give that patient some ephedrine to bring up their pressure. Okay, but we do pre-bolus the patient with a liter of fluid before the epidural to help prevent hypotension. So that's a case where I might be less concerned about lates because I know what's caused it, okay, and we can fix it. Okay, here's a picture of variables. Okay, again, these look a little bit different. But these are clearly variable decelerations. Okay, chord compression. You can see here at the end of that, there's a little bit of an increase in the heart rate. These are not accelerations. Those are called shoulders, and it's just a response to the decrease in the heart rate. Okay, so it's called an overshoot. And it's just due to the baby's response to the variable. It's not an acceleration. Okay, here, what's happening here? Well, we got moderate variability, okay, so we can see that. But we got some pretty significant decels, okay? But if you look at the contractions, the patient's pushing, okay? They're pushing every other contraction. If you see those little spikes, those are pushing marks, okay? So when the patient's pushing, they'll look kind of square-shaped. And you'll kind of see like these 3 spikes because they're pushing. And because of these decels, they're having her push every other contraction. And this is a really good strategy, especially if you're really close to a vaginal birth, okay? And so it just gives a baby a little bit of a breather between. Time enough to like get the baby lower but get a vaginal delivery. So that's really what's going on. And it's not really unusual for the baby to have D cells with pushing because it's getting squeezed. Okay, the cord, everything else, it's getting squished in there. And as long as it's coming back up here in between, we're okay. You can keep going. If you're losing variability and these are getting wider and deeper and longer to recover, then we're a little bit more concerned. We're kind of weighing out, okay, how much more pushing does she have to do? Okay, is the baby going to come out? This is a case where we may consider doing a vacuum if the head is low enough, but we weigh that out to see. Okay, now this is tachysystole. Okay, this patient is, they're contracting too much. And you can see that being reflected in the fetal heart rate. You have minimal variability. It kind of looks like there's a couple little dips up there, but this is something that, you got to get that pattern gone. Okay, you got to space those out because this baby is responding with lower oxygenation. Tachycardia. Okay, so again, 180 beats per minute. The number one cause of fetal tachycardia is maternal fever. Okay, I want you to remember that. And sometimes we'll see the baby get tachycardic before we even see them spike a fever. Okay, once the patient has a fever over 100.4, if we're seeing that along with fetal tachycardia, we will start antibiotics in labor. Okay, so usually that's going to be in the form of gentamicin and ampicillin. Okay, if they're penicillin allergic, we may give clindamycin. And they're going to keep those antibiotics going at least 24 hours postpartum, if not longer if they're febrile. Okay, and this is showing you some terminal bradycardia. Okay, this patient will get a crash C-section. Some kind of insult occurred. She either had a prolapse cord or she's having a seizure. Something is going on, okay, that's causing the baby to have a D-cell like this. So one of the important things you need to do if you aren't in the room and you're seeing this, you need to go in and do a vaginal exam. What's going on? Because that's the only way you're going to know if there's a cord down there. And if you have a prolapse cord, your job is to hold the presenting part off the cord to give that baby oxygenation. And you're keeping your hand in there until that baby's out. So, yep, you're riding on the bed back to the OR and you're keeping your fingers in there until that baby's pulled out. That's a bad day. Okay, let's talk a little bit about cord blood gases. So they can be helpful in determining acid-base status prior to the insult during labor and oxygenation status. So these can help or harm a provider. If they have bad set of gases, we know that the insult might most likely occur during labor. We did not deliver the patient in a timely fashion. If you have a good set of gases, likely it's not related to the timing of delivery. Okay, so what we do is we take a cord segment and the nurse will draw the artery first. The artery is important because that's the blood coming from the baby. Okay, they often clot off though, and it's important you draw that artery first before the vein, because if you draw the vein first, it's going to collapse the artery. Now your gases are going to look better from the vein because that's the blood going to the baby from the mother. But it is important to get both sets of gases. And you should get gases if there's a category or 2 or 3 tracing. Okay, so now these are your reference ranges for the cord blood gases. Usually if it's less than 7.20, we get a little bit worried. It's probably more of a metabolic cause if it's less than 7.0. And you're also looking at the base excess. So the base excess of greater than -12 indicates fetal acidemia. Okay? That's it. If you guys have any questions, please email me and Candace. Thank you.